Okay, so we're going to go over just a few medications. Let me share my screen, and we'll talk about some of the things that were on this practice B. Make sure that everyone is, please, muted. Thank you. All right, metformin. Remember, metformin, medication for type 2 diabetes. Metformin is a drug that needs to be held the day of and 48 hours after any procedure that uses contrast dye, which would include cardiac catheterization, any type of angiogram or angiography, CT scan with contrast, intravenous pyelogram, IVP. All of those procedures use contrast dye. You cannot have metformin in your system with the contrast dye. You'll go into renal failure. So metformin should be held the day of the procedure and then 2 days or 48 hours after the procedure. Metformin can give you a weird metallic taste in your mouth. That's not that big a deal. Tell the patient to get hard sugar-free candy, and that'll sometimes help. Metformin does have an adverse effect potential for lactic acidosis. Lactic acidosis is very similar to rhabdomyolysis. It's a spontaneous deterioration of muscle tissue that causes an acidic condition, and it can be fatal. So if the patient's on metformin and they suddenly start complaining about muscle cramping, muscle pain, muscle weakness, and Charlie horses, anything like that, stop the drug, call the healthcare provider. Remember, when we're talking about sulfa allergies, drugs that have sulfa bases, your loop diuretics like furosemide and bumetanide, and even your thiazide diuretics like chlorthalidone and hydrochlorothiazide have sulfa bases. They can't be given to somebody who's allergic to sulfa. Celecoxib, that NSAID, cannot be given to anybody who is allergic to sulfa. All right. And then, of course, trimethoprim, sulfamethoxazole. Sulfa is right in the name. So that, of course, would not be given to anybody who has a sulfa allergy. Metoprolol, beta blockers, all the LOLs, all have the propensity to cause bradycardia and heart failure. All the beta blockers, beta, bradycardia, heart failure. Don't forget that. When you talk about furosemide and adverse effects of furosemide, remember furosemide, loop diuretic, that is potassium depleting. And so you want to make sure the patient understands about potassium-enriched foods, and they should be eating those regularly. When you have somebody who's receiving morphine or any opioid for that matter, remember this. With opioids, the 3 biggest adverse effects: urinary retention, respiratory depression, paralytic ileus. Yes, opioids cause constipation too. That is something that is manageable and typically doesn't kill somebody. So if we're talking about somebody being on an opioid and we're concerned about constipation, increase your fluid intake for 2 reasons. So you don't get constipated and your body can excrete the drug. Also, make sure you're taking in sufficient amounts of food that contains fiber, or take a fiber supplement, or docusate sodium, also known as Colace. That is a stool softener, not a laxative, and that is absolutely safe to take concomitantly or in conjunction with any opioid if you're concerned about constipation. When we look at propylthiouracil, there are 2 medications that are used for hyperactive thyroid: propylthiouracil and methimazole. And the biggest issue with those drugs is that we reverse the hyperthyroid patient into a hypothyroid situation. Believe it or not, those are the biggest issues with those drugs. So propylthiouracil, you want to make sure that the dosage is correct. Their symptoms are resolving. In other words, hyperthyroid symptoms are things like everything's high and fast, tachycardia, hypertension, hyperthermia. They're always hot. They're very thin. They don't sleep much. You know, they eat a lot, but they don't gain any weight. Usually they'll have diarrhea, oily skin. Everything's in overdrive. If we're giving them propylthiouracil, all those things should be getting back to within normal range. They can start going in the opposite direction and becoming too sluggish. Okay, so that's what to know about propylthiouracil and methimazole. Mycin, so we've got tobramycin, and actually tobramycin is on this report twice. Priority finding for somebody on tobramycin, and medications that are contraindicated with tobramycin. Remember with the mycins, ototoxicity and nephrotoxicity. If somebody is on another drug that can cause those things, then you would be very careful, or maybe even not give them a mycin, right? So for example, Loop diuretics can be nephrotoxic. Maybe you don't want to give them the mycin. Maybe you want to give them a different antibiotic because they don't jive, right? So just look at it that way. And findings to report if they're on tobramycin or any mycin. Are they experiencing a new onset of tinnitus, buzzing or ringing in the ear, which is a sign of ototoxicity? Or are they noticing they're not urinating as much as they usually do, or their urine looks concentrated or has a funny smell to it? That would be problematic because that can be an early sign of nephrotoxicity. So just remember that. Sublingual nitro, I mean, there's not much to talk about that I didn't tell you guys already. Remember, with sublingual nitro, they're going to have a tingling tongue. That means it's working. Replace the nitro every 6 months, whether you need to or not. Keep it in a brown glass original bottle. Keep it away from heat, extreme temperatures of any kind. Keep it away from the sun. They can take 1 tab sublingually every 5 minutes times 3 doses. No relief after the first dose. They should call 911. They may get a headache, and that's because of the vasodilation. It's important to know. Nitroglycerin in general is not just sublingual, so make sure you know. Transdermal nitro, the patch is on in the morning, it's off at night. It shouldn't be on for longer than 12 hours. Transdermal patches should go on as hairless an area as possible, and the sites should be rotated. For nitro paste, also known as nitro ointment, another form of nitroglycerin, it almost works kind of like the patch does, but the ointment goes onto a paper that gets placed on the anterior chest wall, covered by a clear dressing or a plastic clear dressing, okay? But it's the same principle, on in the morning, off at night, okay? And they're long acting with nitro paste, transdermal nitro. You can still take sublingual nitro if you're having an angina attack, even if you're on transdermal nitro or oral nitro or nitro paste. That doesn't mean you can no longer take sublingual nitro. You can. Make sure if the patient's on any corticosteroids like methylprednisolone, it's important to understand that long-term use of corticosteroids can cause Cushing's syndrome. Hyperglycemia, you want to check labs, you want to make sure that they don't have elevated glucose levels. And corticosteroids like methylprednisolone can cause a suppressed immune response. So you're going to be checking a CBC to make sure that they're not neutropenic and teach them signs of infection like fever, sore throat need to be reported immediately. Sumatriptan is medication for migraine headaches. You want to make sure that the patient understands that there's a side effect called a vasospastic response, chest pain. That's important to tell the patient if that happens, they need to stop the drug and call the physician. Mag sulfate toxicity, if somebody's getting mag sulfate because of preeclampsia or eclampsia or potential preterm labor, you always check deep tendon reflexes. If they are sluggish or absent, that is a cardinal sign of mag toxicity. They would need the antidote, which is calcium gluconate. Methotrexate is a chemotherapeutic drug. It's an anti-neoplastic drug. You want to make sure the patient understands that it suppresses their immune response. They're going to be neutropenic, possibly, risk for infection, thrombocytopenic, risk for bleeding, and possibly anemic, risk for anemia. And make sure they're taking in plenty of fluids to also help to excrete methotrexate. If your patient's on epoetin alpha, Epigen, to stimulate red blood cell production because they have possibly renal failure, anemia, you want to make sure that they understand, we're looking for their hemoglobin to rise. If the hemoglobin is already normal, you might not want to give them a subsequent dose. You may want to call the physician and talk to the physician about any subsequent doses of that drug. Remember exenatide, which is an oral drug for type 2 diabetes. One of the biggest potential adverse effects is pancreatitis. If the patient complains about severe abdominal pain, new onset, stop the drug, call the doctor. Risperidone, right, or Risperdal, which is an antipsychotic. Make sure you understand about extrapyramidal syndrome, all those weird, involuntary, awkward movements of the limbs or the face, lips, mouth, tongue, tardive dyskinesia, but also it can cause hyperglycemia. Make sure you're checking blood glucose levels if risperidone is being administered. And that is enough of a present for everybody. I'm going to stop the share and